Good afternoon and welcome, everybody. I'm Kim McGrail, and I'm a professor in the School of Population and Public Health in the Faculty of Medicine and Director of Research at UBC Health. Thank you for joining us today for our next session in the Health After 2020 dialogue series. Before we start, I would like to acknowledge that UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to acknowledge that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places near and far. I acknowledge the traditional owners and caretakers of these lands. Today, I'm joining you from the traditional, ancestral, unceded territory of the Coast Salish peoples of Squamish, Tsleil-Waututh, and Musqueam nations. I'd like to make a few comments about UBC Health and the Health After 2020 program before introducing our speakers. UBC Health works under the Office of the Vice President Health. We recognize the growing need for collaborations to address complex and interconnected problems facing society. We facilitate collaborations across disciplines, faculties, and campuses, as well as with partners and communities. Our work enables us to improve the ways we collectively train people, develop knowledge, and shape policy. Our ultimate goal is to address inequities and improve the systems that foster and support health. Through our initiatives, we aim to foster an active community of health research practice and mentorship. The UBC Health Dialogue Series brings together scholars, students, and community partners to discuss important topics related to the health and well-being of society and to advance interdisciplinary knowledge translation. Our understanding of the determinants and experience of health and well-being has changed. In 2020, the COVID-19 pandemic accelerated some existing trends and put a spotlight on others, and we are now responding to the broad effects of the pandemic. We have the opportunity to learn from our collective experience and to think differently about how we define and value health, how we understand the complex systems that produce health, and how we rise to the challenge of supporting equity in health across individuals, communities, and societies. In response to this opportunity, UBC Health developed Health After 2020, a program designed to support researchers to engage in interdisciplinary collaborations and build a community of UBC Health scholars. Through the development of research collaborations, academic outputs, cross-campus conversations, and open dialogue sessions, the program convenes and informs people at the inflection point in our society created by the COVID-19 pandemic. 8 interdisciplinary teams have been funded during this inaugural year to advance and disseminate their collaborative research, which includes leading a dialogue session like today's. Today is the next session in our Health After 2020 dialogue series and is titled Exploring Barriers and Facilitators to Health Equity, a public dialogue to advance research agendas related to opioid prescribing for pain conditions. Our speakers are Dr. Rita McCracken, Assistant Professor in the Department of Family Practice and Faculty of Medicine at UBC, Dr. Colleen Barco, Professor from the School of Nursing and Faculty of Applied Science at UBC, Fred Cameron, Acting Operations Director and Harm Reduction Manager from Solid Outreach Society, and Shaunanarayan, Research Analyst from the Department of Family Practice, Faculty of Medicine at UBC. Please welcome Rita to start us off.
Thank you, Kim. Thank you so much for this opportunity. I'll just say a couple of words about how we ended up here, and then hand it over to the speakers that I'm so delighted have been willing to join us today, and in preparation for what we hope will be a very rich discussion at the end of their short presentations. So I'm a family physician and a researcher in the Department of Family Practice, and I got involved after my PhD studies into improving prescribing in primary care in a project where our main goal was to help improve the safety of prescription of opioid medications for acute and chronic pain conditions. Nothing related to substance use disorder treatment or people who use drugs. However, in the course of this research, we have discovered through our qualitative portion of the study, our best intended messages regarding safe prescribing for acute and chronic pain, we have uncovered a major barrier to appropriate patient treatment for all the conditions that a person brings. So in primary care, we treat a whole person. We are not specialists in one part of the body or one phase of life. We look at everybody at a whole time. And so our best intended, well-intended messages regarding how to more appropriately prescribe opioids, we realized were somehow being distorted and potentially causing increased difficulty or barriers to care for other conditions, even peripherally or only historically related to prescribed opioids. And this really raised major concerns for myself and the other researchers on this project about how the factors of equity that we had not considered earlier on in our research design, and became very motivated to ask people who have different perspectives about this in order that we can inform our own research agenda and possibly create a larger dialogue about how research agendas need to be transformed in the future. So on that note, our first speaker today is Dr. Colleen Varco, who has made a concerted studies regarding equity in primary care. And I've asked her to give us, condense her entire body of work into 10 minutes to help orient us from her perspective to this problem. So thank you so much, Dr. Varco, for being here, and please take it away.
Thank you very much for inviting me, Rita. It's just lovely to have everybody come together. And as Rita said, I'd like to talk to you about the issues that we've been studying over the last couple of decades, which are structural stigma, discrimination, and inequity. And I'd like to first acknowledge that I'm coming to you from the unceded territories of the Shisha people, who are self-governed since 1986, not part of the Indian Act. So kudos to the people that have protected this land over millennia. I thought that what I would like to contribute to this dialogue in the next 9 minutes or so is some ideas about structural stigma and discrimination as they relate to the topic of accessing care for chronic pain treatment, chronic and acute pain treatment, and really focus, as Rita's asked me to do, on the structural and organizational features. So just to give you a quick snapshot of the work we've been doing over the last several decades is we started studying, first of all, the impacts. I study violence, and particularly violence against women, its relationship to chronic pain and so on. But then I had to very quickly shift to studying racism and discrimination because unfortunately, violence is inappropriately stereotyped as being associated with particular ethnic groups and particular income groups and so on. So having studied that, colleagues of mine and I began to look at how was it that some organizations, particularly primary care settings, were providing really excellent care to highly marginalized groups of folks. And we identified what we called the key dimensions of equity-oriented care. And then we tried to turn it into an intervention to better support primary care settings. We did that, and then subsequently have done the same thing, trying to do an organizational level intervention in emergency settings. So we're just wrapping up that study. And all along, we've been developing tools for practitioners and organizations to enhance their care. And then we just finished a 2-year grant from the Public Health Agency of Canada, really strengthening attention to stigma related to substance use. So that's what I'm bringing to you, that body of research. And I wanted to just mention that we have evolved this understanding of the key dimensions of equity-oriented care, but believe them to be requiring trauma and violence-informed care, culturally safe, anti-racist care, and harm reduction, which we're increasingly framing as substance use health. We've identified the strategies that can achieve these and created a bunch of tools in an action kit that can help organizations to do this. Our studies have shown not necessarily that we can really impact health outcomes for patients through our intervention work, but we have demonstrated that this kind of care really matters. And interestingly, although my research on supporting violence, women who've experienced violence, has not been able to move chronic disabling pain, this kind of care we have shown can do that. So when patients felt they had equity-oriented care, as I've described it, we demonstrated they had fewer trauma symptoms, better quality of life, less depression, and interestingly, as I said, we were able to move chronic disabling pain. So from this, the primary care work that we've done, the key messages that we've pulled out is that in healthcare, the physiological intersections among trauma and violence, chronic pain, substance use, and were terribly understood. We're not well understood by practitioners at all levels, and actually organizations and policies are not designed based on that understanding. Importantly, the intersections among multiple forms of stigma operate to really drive people from care. Stereotypes about drug seeking also intersect with racism. So if I'm identified as an Indigenous person, I'm much more likely to be assumed to be, well, drinking, but also drug seeking. So we know, and I also had the privilege of being on the advisory for the Canadian Task Force on Pain, and we know that chronic pain is undertreated in primary care and other contexts. And we really witnessed that physicians, in particular providers, prescribers, are put in the position of having to judge whether pain is quote unquote legitimate or not, which overlooks the fact that violence, trauma actually changes your ability to regulate pain. So overarchingly, abstinence, it just dominates our thinking. When we ask prescribers or care providers of any kind, what's a success story look like? Invariably, people say, well, so-and-so's been clean and sober, something like that, some language such as that, which is, in itself stigmatizing, but also really reflects that abstinence is the goal. And we've seen that in policies as well. So in our emergency study that we've just finished up, again, we just continuously see that stigma and discrimination is pushing people away from care. And we saw that manifest in the emergency setting in the numbers, high numbers of people that are leaving without their care being completed. So again, stigma and discrimination are just not a matter of individual providers, but how we structure care. So healthcare providers in the emergency are really pushed to get people through as quickly as possible. And although they're supposed to be triaging based on acuity, they end up triaging based on social circumstances of people's lives. The good news is we have been able to show a significant decrease in the numbers of people who are leaving without their care completed. So I think there is hope. Finally, in that work we've been doing for the Public Health Agency, we have a number of key messages. First of all, the direction, and I don't just mean input, I mean direction from people with lived experience of substance use stigma and substance use is the most important thing, and yet it's the least enacted thing, I would say. I think that we continue to see abstinence only as a big problem in policy, practice, and culture. We have seen how this siloing of systems is really highly problematic and again, deterring good care. I think that people are going to continue, providers and people coming for service, to struggle unless we really move forward on legalization. And finally, we are not seeing the kind of sustainable commitment. We see a lot of one-off projects in terms of equity and stigma reduction, but not that sustained kind of effort. And so we've created a lot of tools. If anybody's interested, they're all publicly available. And one of these things that we're really trying to shift people toward is toward the idea of substance use health, making it as normal as your mental health or your physical health, and really trying to destigmatize, the idea of substance use disorder. A lot of people use substances in a range of ways. Not everyone has a substance use disorder, and we've got to learn to, I think, talk from that angle. So I think those are the messages that I wanted to bring to you, and just to say we have kind of essential messages and videos in each of these things if you're interested in anything further. So I hope I didn't go over time there, and I'm going to stop sharing.
Thank you so much, Colleen. That was a wonderful snapshot into the work that you've been doing. And even though we've spoken about this before and I've read your work, I already have some new ideas. So thank you. We will jump over to our next speaker, Mr. Fred Cameron, who's going to be providing us a very important perspective from his organization that provides support to people with lived experience. Fred, thank you so much for joining us today, and please take it away.
Thank you. Yeah, I am Fred Cameron. So there's been an update, I guess, since I sent in that bio. I'm now the programs director at Solid Outreach and not acting. So I guess, let me just stop and think for a moment. I work on a number of research projects, as well as I run the team, which is made up of about 90 drug users on staff. And then we have approximately 2,000 official members, but I would guess somewhere in the 1,000 to 1,500 in good standing active users of our programming. We are essentially the Drug Users Union, and that was born out of a group of middle-aged men who got tired of being pushed around by the police about 20 years ago, a little bit less. And that has grown into, we're now street outreach. We run the harm reduction services in 4 supportive housing units. We're one of the service providers that run the harbor and an inhalation site. So we're hand in hand with the health authority now. We've just had an enormous growth in recent years, and that has been sped up exponentially by the COVID pandemic. So I'll just back that up, I guess, to 2020 in March. So I was a student at Camosun College, and I was working part-time as a supervisor in the harbor. That's the safe consumption site, which is the biggest on Vancouver Island. And then COVID hit. So on the 15th was when my school shut down. And by the 21st, all services on Pandora and in the downtown core of Victoria were closed. So the staff was still inside because they were union workers, but quickly it went from about 40 people living on the 900 block of Pandora to about 350 overnight. And these are people that didn't have access to bathrooms, healthcare. Something that we had all but eliminated was people reusing needles. People were finding discarded needles on the ground and having to relearn how to sharpen them. So everything that we had gained over the past 15 years was lost in that community for the first few weeks. That service shut down entirely. So myself and another individual went down with the tent, and we opened up our own safe consumption site. And then we invited the health authority to come and join us in working there. And then we passed the service on to the Lookout Society. I'm going to be honest with you, we didn't know what COVID was. Our workers we watched the news. A lot of people don't have phones, so it's word of mouth. We didn't know if we were going to die, but we went to work every day. And very quickly, BC Housing bought some buildings and we moved everybody into housing sites. And I'm just remembering what it was like when the risk mitigation guidelines went through. So very quickly, the primary goal was to keep people still or keep people stationary to avoid the spread of COVID. And everyone was being prescribed Dilaudid. There were a few others that were prescribed. Initially, people were quite excited, but we didn't realize at that point just how strong the hold was that fentanyl had on our community. There was no longer any heroin available. Even now, a couple of years later, when the supply has improved a little bit, every few months we see a small amount of heroin come through town, and it doesn't work for most people anymore. But basically, the program was good to make a step. But looking back at it, Dilaudid simply didn't work. But that was the only thing that was available. But one of the other things that came with that, I didn't really know what to talk about with this because I have so many things on the go. So I just phoned a few different people who have done research work with us or have been participants in other studies to talk about looking back, what it was like and what it's like today, 2 years into the pandemic. And one of the things that's still rings in my head, he said, prior to COVID, we had such a conservative stance through the medical system as well as in the government around drug use. And he said, we've had just a rush of liberal thinking that came in. And one of the things that he said resulted was it's now difficult to get healthcare that's not around drug use. So he said, things like pain medication or going to see a doctor if you have a sprain or a wound. It's easier to get help with drug use and safe supply than it is to go and see a family doctor regarding day-to-day health. I hadn't even thought about that yet because it seemed like there's so many more services are available. Just a bunch of money came in. There's 14 housing sites that I know of right now that are supportive housing in Victoria, and it's probably more than that even. So much support came in, but somehow it's harder to go out and get medical help. Another one that he added, even beyond the struggles of the drug using community, which is, that's who I'm in touch with on a day-to-day basis, but our outreach workers that are out in the community, they always send people to a place called the Kool-Aid Clinic, which is the downtown clinic for people who are on social assistance. There's a dental clinic as well as healthcare, primary healthcare available. And basically he was telling me that you can't get help right now unless you're a drug user. So it's become more difficult to get healthcare. It blows my mind with the amount of people and the amount of focus that's gone into this. A few other things that I heard, which have rung true all along. But the treatment that we're offering and that I'm trying to help people to get hooked up with, it's almost as if it's not based on the individual needs. And in quotation marks, I'm going to say, my friend basically said, when he goes to see a doctor, he feels as though they're seeing the condition as, a drug addict, and they're treating people as such. But their understanding is not based on the individual needs of the person. So he again goes back to pain medications. This is someone with a bad neck, as well as fentanyl addiction. And he said basically that the timeline is not based on the individual. So he has to go in and use on the schedule of the clinic that he's taking part in. And if he isn't able to do that, he loses his carry. And sometimes even they cut back his dose, which almost every time results in the person going back out and buying street drugs. it's almost, it's just self-perpetuating. If we don't offer a service that we're able to keep up on an ongoing basis, we're going to end up back at the same point over and over again. So, I have seen, again, huge gains made over the past couple of years. So as an activist, I'm working right now on both the federal and provincial decriminalization movement, and I think we're getting pretty close on that. I work in a research team with the SAFER project, which is Health Canada funded pilot project offering safe supply. And I'm also a researcher with a group called Substance, which is a drug checking project that operates out of our building. So there are so many new services available to people. But right now, it's just not designed for long-term success. One of the things that I have in the training, when we hire people and we bring them up very slowly through street outreach, they clean up the community, they work in housing sites and then a safe consumption site, is we don't offer something that we're not going to be able to follow through with. And that was very clearly demonstrated with the risk mitigation. We started a program, offered drugs that we thought might work. We didn't do the research and get the drugs that the people needed, and we lost the faith of the community. It's good that we made that step. It's part of this is a very long narrative. This goes back to the 1960s and probably even hundreds of years, but that's where my story starts. But we failed, I'm going to put it in simple terms. So it's not over. This is an ongoing story. I think, we're going to look back in a few years, and the overdoses, hopefully we're going to get that under control. But drug addicts still don't receive the same healthcare as the general population. I've come a long way since I was in active addiction, and I still today even can't get access to healthcare. There are no family physicians in the city of Victoria that I'm on a wait list, just like so many around here. But when you're starting every day, you're starting again, as we see in the drug using community. It's just impossible to gain traction and build a foundation. So I'm open to any questions here. I can put my email in the chat. I probably raised more questions than I answered. But thank you so much. It's been an honor to take part.
Thank you so much, Fred. Really appreciate that. And again, I encourage people to add things to the chat. We have one more speaker, and then we're going to go to question answering. Before I introduce our next speaker, I'll just ask Veronica to post the poll. We just want to get a little bit of reaction from the crowd, some answers to who you are, what some of your thoughts about this issue are as you are arriving to this dialogue. And so it will be posted for a few minutes. Just on the side there, take your time. It's completely anonymous, by the way. We will not be following up with you about why you answered in a certain way. And so I will invite our third speaker, somebody very close to me in this work, Ms. Shaunanarayan, who very recently was a student herself, and I anticipate will probably be a student again, but has been working with us on our project, capturing the qualitative data that we have been exploring. And today is going to specifically talk from the perspective of what we've heard from new trainees in family medicine about this work, and what are some of the conflicting messages, what are they hopeful about, and what we've been able to take away from those conversations so far. So Shauna, thank you.
Thanks, Rita, for that introduction. Somebody give me a thumbs up that they're seeing the slides correctly. Great, thank you. Hi all, I'm so glad to have you join today's dialogue session. I'm joining from the unceded territories of the Kwantlen, Wassanek, Tawasin, Kutsi, Semiahmoo, and Coast Salish peoples. I'm excited to share a trainee perspective from Vancouver family medicine residents on the management of pain and opioid use disorders. I wanted to start off with this quote from one of the residents. There are so many systemic factors that are outside of patients' control that we as physicians have a duty to try to provide the best care we can. After learning from Colleen and Fred's presentation, it's clear that there are many inequalities that contribute to barriers in accessing care. And this presentation will touch on a few more of those. This quote gives me hope for the future of healthcare, and we can brainstorm in a discussion about how we can move healthcare and research forward. And I hope in the discussion that I can also learn from you. So I'll be sharing the perspectives from family medicine residents, and these are individuals who have completed medical school and are now training to become a family physician after 2 years of additional training. Rita mentioned that I was part of the Redona study, and this study aims to reduce inappropriate prescribing of opioids in primary care. And it's a much larger study in which this qualitative spin-off study came from. In the Redona study, we heard from family doctors, nurse practitioners, and residents, and learned how training experiences influence their prescribing practice, among other factors. So we thought, let's see what current family medicine residents say, specifically residents from St. Paul's program. We wanted to learn more about opioid prescribing experiences, their attitudes and feelings about opioid prescribing, how social determinants influence prescribing practices, including factors like racism, stigma, income inequality, and lack of affordable housing. We also wanted to see how we can improve training. We asked residents about what their ideal training would look like and if they could identify facilitators and barriers in the program for opioid agonist therapy. So when it comes to prescribing experiences, residents prescribe for opioids for pain management and opioid agonist therapy for individuals with opioid use disorder. When managing pain, residents described identifying, the type of pain, its origin, and then considering both pharmacological and non-pharmacological options. They were aware that common practice is to prescribe a short course of medium to low potency opioids for acute pain, despite what research says. And Rita has a great webinar called Think Twice that's available on the Therapeutics Initiative, talking about what research says and how it might not be the best option. Residents also refer patients to allied healthcare, such as physiotherapy, massage therapy, but these options can be limited for patients without extended healthcare. And residents' experiences with opioid agonist therapy often came from the clinical rotation at Three Bridges. So one resident suggested that they view it as another constant medication in the sense that these individuals have a chronic illness and they need this medication. When we asked about how residents feel about prescribing opioids, we learned that some residents were confident in their ability to prescribe opioids and others had some significant concerns. For example, challenges with managing patient expectations and the actual effectiveness of opioids for chronic non-cancer pain. So residents agreed that factors such as systemic racism, income inequality, lack of access to affordable housing influence their prescribing practices. And here I'll share a quote from one of the residents. Patients who are from the downtown east side are fairly entrenched in drug use and who have experienced a lot of systemic racism and income inequality and lack of access to affordable housing. I think it gives us more impetus to try and treat progressively and to try and manage with less conventional options so that we can try to address their substance use needs a little bit more accurately. Residents are well aware of situations where people of color and Indigenous people are being under-prescribed pain medications, or like Colleen mentioned, like maybe their pain is not being taken seriously. And individuals with opioid use disorder are being under-prescribed opioids. One resident also shared if they're worried about the current drug supply and their patient's substance use, they will aggressively prescribe OAT, or opioid agonist therapy, with a safe supply. So switching gears to training, we learned that many residents do not remember lectures about opioid prescribing. One resident said that they did not know about opioid prescribing before the residency. And if you notice from my previous slide, residents go through 4 years of medical school. This resonated with residents as many of them agreed that medical school opioid prescribing content is limited or still very young. They agreed that there were few lectures about addictions, and they don't remember much of the undergrad specifics about opioid prescribing outside of pharmacology. And it's really interesting to hear that they don't recall receiving this information, but I have gone through UBC's medicine curriculum to see what content is available, and there are lectures and other types of learning activities related to this topic. So this points to the need for more impactful training for our future physicians. When it came to discussing the residency training, most residents agreed that the current St. Paul's residency program is their ideal training. Residents felt that there are many opportunities to experience different sides of caring for people who use substances. The opportunities are niche and nuanced as you want, and it's a fulsome addictions training residency if you'd like it to be. There was also opportunities to complete chronic pain electives in clinics. Another factor was the quality of resources and teachers, with the residents sharing that there are really good clinical resources and teachers to guide you through the residency. And something that really shined through the discussions is how much residents valued the clinical experiences. And a lot of this had to do with their rotation at Three Bridges. So there is a lot of community integration, which provides an understanding about specific local context, how it influences their patients, and its potential impacts on their substance use. They shared that at Three Bridges, physicians do things a little different compared to what they've seen at other clinics, since they're ahead of the curve, and that's where they do most of the opioid agonist therapy. The physicians are very well versed in it, and everyone's completed the opioid agonist program. There were a few gaps that residents mentioned in the program. First, there's limitation to the guidelines. Residents take the time to learn these guidelines, but clinical experience is what really provides key learnings. For example, one resident says, guidelines can never keep up with what is actually being done. Just because guidelines are a little bit behind the illicit fentanyl supply on the streets, it's a safe baseline for folks who don't practice addiction medicine on a day in, day out. It's generalized for the public because not everyone who uses substances is entrenched in the downtown east side. Another challenge was the extracurricular time needed for the POETS-P course, which is the Provincial Opioid Addiction Treatment Support Program that trains prescribers to diagnose and treat opioid use disorder. This course takes at least 8 hours, and residents have to complete 2 half-day sessions with preceptors, although residents did share that that was very valuable for them. They desired dedicated time to complete the POETS-P course within the residency program structure. For example, if the program doesn't specifically set aside time, that's signaling to the residents that this is an optional add-on thing to do. But in reality, the residency program would like them to complete the training, and residents would also like to do it. Lastly, residents would like more information and skills on managing patient expectations in complex cases. What do you do when a patient is expecting to receive opioids? What if a patient doesn't have a family doctor? There are concerns about inheriting patients and the person who's going to be following up with the patients later on. So this brings us to what we can do to improve training given the recommendation from residents. There should be an evidence-based review of guidelines to provide a solid foundation for experiential learning. We need a balance of different types of learning experiences, such as class-based, experiential, inpatient, outpatient care, experiences with providers who are expanding the scope of guidelines, and we need protected time to complete the POETS-P accreditation program for residents. Being able to prescribe OAT is a fundamental basic skill of a family physician. And this is a quote from one of the residents. And we should support this by improving the education family medicine residents and medical students receive. So where do we go from here? This is a snippet of just a small piece of the conversation that we have with trainees and their experiences with opioid prescribing in both pain management and treating opioid use disorder. Training must be explored further as it's an area that's that can be equity-oriented health care practices can be applied to. There needs to be effective undergraduate education in the topics of pain management and opioid use disorders. And the recommendations from residents should be implemented into the programs. And I'm very excited to say that the team with UBC's St. Paul's Residency and our research team has been able to get protected time for residents for OAT accreditation. We also need more research on this topic, specifically with other residents. And I'd like to mention that this group included keen social justice-minded residents. So these findings are not necessarily generalizable across the province. And again, like the residents, we had about 20 residents. This is just a subset of that with those from St. Paul's. So that brings me to the end. Thank you so much for taking the time to listen to my talk. I welcome your thoughts and comments during the discussion period.
Thank you so much, Shauna. And thanks as well to everybody who has been posting in the chat, which is great. I'll just put the results of the quiz up here. We have a diverse group of people, not just all doctors, which is lovely. And no surprise, the people who've come today are very concerned or extremely concerned about equity issues related to evidence-based pain management, and that there is 100% agreement from respondents about attitudes and stigma about drug use affecting patients who are seeking pain-related care, and attitudes and stigma affecting doctors and prescribers as well. And then the points that we had identified prior to this that we thought, and that the evidence suggests are elements that need to be considered are the stigma related to drug use, medical legal requirements by physician licensing bodies, the family doctor shortage, federal and provincial policies regarding safe supply of drugs, racism, colonialism, poverty, and or housing insecurity. Are all factors that this group who have responded seem to be important to this discussion. We'll ask Dr. McGrail to help me facilitate the question period here. There was lots of great content added to the comments, and I welcome anybody with specific questions to pop them up right now.
I'll get things started. I'm hoping I'll just look for hands or questions in the chat, but I was following the chat and I want to put a few kind of comments together. This is going to be maybe a super hard question, but it seems to me to kind of get to the nub of a few things that were being said. And that is, I think about Dr. Barco's presentation and really kind of highlighting the importance of intersectionality. And it's, both there's this intersection in that Venn diagram of the different approaches to care and frameworks for care that she was talking about, but also just the intersectionality that relates to stigma and racism and all of those other things. And then Fred's comments about the difficulty or impossibility of getting personalized care, which I interpret in many ways as being person-centered care. And I mean, I think we all kind of know that person-centered care is supposed to be something we value, but it doesn't exist for very many people at all. Like, you're lucky to have a physician, I think, who provides person-centered care. And so I'm just wondering if you have thoughts on this kind of additional, like, is this an extra problem for people with chronic pain or people who use substances, or is it just kind of part and parcel of all the problems in our primary care system right now? We'll start easy.
You want me to answer that?
Yeah, I do.
Okay. Well, yeah, no, I mean, I was really struck as well when Fred mentioned the several examples of how lack of access to primary care is directly affecting people who use drugs, not necessarily about their drug use, and how that is a very significant component of their drug use and being able to use safely and that kind of thing. So I think we have a massive problem with the infrastructure for primary care right now. And one of those elements is how we are running primary care right now. In the vast majority of places, it's hard to do patient care when you're trying to see 6, 7, or 8 people an hour. it's hard to ask the questions and connect with people when you're worried about the fact that 2 of your office staff are out with COVID and one of them has just handed in their resignation and you're going to be answering the phones yourself next week. So we've got this infrastructure element that is really taking away from, even if people had the right attitudes and the skill sets to be able to do it, it's very hard to be doing that. And I think Colleen's work has really beautifully laid that out. Here's what we need, yet we're stuck with this fact that we don't have it. We don't have it right now, and we're trying to do things like improve prescribing for acute and chronic pain, but at the same time in this larger field of where there are huge groups of people who aren't getting the care that they need, and at higher rates than other people. So no, Kim, I don't have an answer to that.
Yeah, no,
but
I mean, it just seems like it's we have to solve that sort of fundamental problem about primary care in general, and then on top of that, kind of deal with the additional issues. And I'm not saying that needs to be in that order. That's not my place to say that, but it does seem related. So that I'll just move on to the other thing that seemed to be coming out in the chat is this notion of how do we even understand pain and chronic pain. And again, Colleen sort of talked about that we don't necessarily even potentially diagnose it because it's not valued or seen as legitimate in certain kinds of people with certain kinds of experience. So is there, like, what is the right way to approach understanding pain and chronic pain and much less, so diagnosing, but then also treating?
Yeah. Well, you'll be interested to know that in British Columbia, for some strange reason, we don't even have acceptable diagnosis codes that are directly related to pain that primary care clinicians can submit. So every time you go to the doctor needs to come up with 1 to 3 different codes that explain why you're there, like a cold or stomach pain or that kind of things. And there's a set of classification codes that normally deal with pain. And I don't know why. There must be some historical reason why that set of codes was completely left out. And I feel like that is a really good structural example of how we're facing this, that we don't even have a space to talk about what pain is. We're always putting it to the side of something else and not looking at it about how it fits in with the whole person. So I'd love to hear from Fred. I don't want to put you on the spot, but you had specifically mentioned a couple of the informants that you spoke to about their experience of pain and how it relates to their overall success in feeling healthy.
Yeah, I guess I should just add the primary service that I'm able to offer is I can offer a job to people that can't get hired anywhere else or nobody else will hire them. The sense of well-being and the ability to eat on a regular schedule and just all of the things that we take for granted are reliant on being able to wake up in the morning and get out of bed and do the same thing that you did the day before, essentially. A lot of our people, when they start out with a neck injury or something along those lines, and if they get labeled as a drug user, they don't get enough medication in order to function on a day-to-day basis. And that just goes into every aspect of their lives. They're not eating, they're not sleeping, and then they end up with other health concerns that come with it. There's depression. A lot of people that once they get too tired or they're living outside, they end up with skin infections. There are just so many things that stem from not treating pain from the start.
Yeah, and I think it would be safe to say that to date, our randomized controlled trial studies regarding pain treatments haven't incorporated those stories, haven't incorporated the aspects of people's lives that are related to their pain, and might augment it, might improve it. And so we're using research that has been done in oftentimes very artificial ways, and possibly with design features that might have significant bias related to who's funding the research, that kind of thing, that we're then trying to apply to a group of people with these like the glasses of stigma. And, you should just be abstinent. That will make everything better, as an approach. And so, yeah, the well-intended, evidence-informed messages about reducing opioid prescribing to reduce the amount of opioids that are potentially being diverted or misused, it really, it's only looking at a tiny component of the larger story. So Fred, I'm sorry if I interrupted you there. Do you have anything else you'd like to add?
I'd like to add just really quickly one anecdote. A dear friend of mine who unfortunately we lost, he was formerly a foreman on a construction crew. He owned a home. He had a boat for the weekend. And an injury took him away from his job. And he lost everything that he had, but then he was prescribed OxyContin a number of years ago. And that allowed him to get back into the world. He got a job. He started to get his life together, started seeing his family again. And then they stopped prescribing Oxy. Up until that point, he had not been a user of illicit drugs, and he ended up going to the street because he couldn't stand upright without the Oxy. So I know that there are a lot of people who are hesitant about prescribing opiate painkillers. But when managed, this allowed a man who had lost everything to live his life. So I know it's a double-edged sword, but we've got to be moving towards something that's, focused on improving quality of life.
This is so complicated, obviously, but there are people at the end of the complication. So somehow we've got to work through it. And I'm just curious, some things we've seen in the chat about that there's the training of the newer generation of healthcare providers and these groups that you're seeing come through with the kind of correct or more nuanced and person-centered orientation. Does that give you hope, or does it feel like the drip needs to be made larger somehow? And are there other things we should be doing on top of the residency training?
Yeah, well, I will say one of the things that we were really kind of horrified to realize is that there is no mandatory curriculum regarding how to treat opioid use disorder, how to treat substance use disorder, nor how to prescribe opioids most effectively in primary care practice. And when I bring this up with other family physicians, I say, imagine if we had a training program that didn't teach you about pregnancy. So even though only about 20 to 25% of family doctors actually deliver babies, we all get training about pregnancy because it is a fundamental aspect of humanity, and drug use is a fundamental aspect of humanity. We might love to believe, I don't have any drug users in my practice, but that is completely preposterous. I don't have any teenagers having sex in my practice. No, that's not happening either. These are things that people who are the front door to the healthcare system absolutely need to know about. And so I think a little bit of activism is going to be needed to ensure that we are able to get this essential training happening, because we're seeing that the trainees, they're into it. They want to know about it. They're not afraid of it. They're not coming in with that stigma or that fear of, I'm going to get in trouble as a prescriber if I prescribe this. And so I think we need to be doing some work at that level. I see that Barb has her hand up. Go ahead, Barb.
Thanks. I think that these are really important issues. I'm an information systems professor, so I work in business schools and try and help health systems and advance that side of it and the information that's sent out there. And I did a study during COVID, and we tried to find information on pain management and had a very hard time. So it was all disjointed. There just was a gap of it. So I guess I just want to echo the importance of this gap and trying to get a group like this to say, you know what, maybe pain management across all the disciplines and the silos might be a really important first step. Because my mother had a hip operation during COVID. And so I was her pain management person. And I have to say there was a few hiccups in getting that information from the doctor to me, because they were telling her that, but she was in a lot of pain and didn't quite understand what they were telling her. So getting it to the people who are the care providers. And fortunately, I knew enough to say, okay, something's missing here. And I kept asking. But yeah, so like what Fred is talking about, like if you go down that route and so it's like, how do we get the caregivers and this pain management information more central? For me is really would be a huge step forward. So that's my comment.
Yeah, Barb, you've touched on a lot of things there, and I'm conscious of the time. But I think that your point about when we're structuring research projects, we really need to be looking at what needs to get done overall versus what we think would be convenient and handy to work on right now. And making sure that we have a widely diverse team who's going to be able to inform that. And just because we're almost out of time, I just noticed a comment from Dr. Amanda Sloan-White, who, Amanda, yes, I know we love to believe that prescribed opioids are the problem that's going to fix the toxic drug supply overdose crisis. And of course, that is not the case. Historically, there is some evidence that prescribed medications were part of the problem, and then physicians and medical education just glommed onto that. Oh, well, we'll just fix how we prescribe, and then that will fix all the problems related to deaths from overdose and drug use and everything. And yes, we need to continually decouple that. And so that is something that we're doing in this work. And one of the outcomes we hope we will be able to emphasize very, very loudly that can't be the case. But I think as researchers, we all need to be doing that. Kim.
Thank you. So I must say thank you to all of the speakers for an excellent and engaging session, and to all of you for joining us. I think there's a really, really important message in all of this about taking equity seriously and really trying to address problems that are entrenched and that are going to be very uncomfortable for a lot of people to face, because it challenges who we are and how we look at our fellow human beings sometimes. So I do also want to make sure that you're aware of our next session in the dialogue series, which is happening on May 11, which is going to be about engaging patients before and after childbirth from all walks of life. And I will also encourage you to sign up for the UBC Health newsletter so you're aware of other events and opportunities. So once again, thank you so much to all of the speakers. That really, it's a very powerful session. And enjoy the rest of your day, everybody.